pathology of the GI tract. Okay, so basically when we talk about GI tract, it includes those daripada starting from our mouth, okay, goes down to the esophagus and then to your stomach, and then of course your colon lah, okay, your intestine, sorry, not colon, intestine, okay, small bowel, large bowel, and then up until your rectum and anus. But of course I couldn't cover everything, so I've only included yang the common ones that we see every day in the ward or in the clinics. Okay, so okay, I hope what I'm trying to do today is not a one-way discussion. I hope I can get questions from you. Like I've mentioned just now, I'm assuming that you have gone through the slides. So perhaps you have got some questions or something that you do not understand regarding the topic. You may want to ask me, or we can discuss it together. Ada tak apa-apa soalan you all tak faham pasal tajuk ni? Because I am not going to go through the whole thing ataupun the whole slides lah. And before that, can everyone of you log into your iTag link for today's attendance, alright? Ada soalan tak? Yang you all tak faham ke?
Doktor.
Saya.
Okay, untuk yang inflammatory bowel disease tu, sebab saya tak sempat nak go through slide, saya tengok video. So from inflammatory bowel disease tu, saya macam tak boleh nak beza sangat lagi between Crohn disease dengan ulcerative colitis tu.
Kita go from the beginning lah. I just go through the slide very quickly. Kalau macam you all ada tak faham, you stop me, okay? So ni stomatitis ni biasanya ulcers lah, mouth ulcers, like what I'm having right now. I have 2 ulcers in my mouth at the moment. Okay, so sometimes ada certain people, they have recurrent ulcers, and probably after we've excluded all the causes, mungkin dia ada vitamin B deficiency ataupun dia ada apa nama ni, ulcerative colitis ke, okay, because the whole intestinal tract the whole intestinal tract is macam interconnected, okay. So you can see, you can have people with recurrent ulcers. They have recurrent ulcers coming in like dalam seminggu ataupun dalam 1 bulan tu, mungkin 2-3 kali dia dapat these ulcers. So kita panggil nama lain dia aphthous ulcer ataupun stomatitis lah. Okay, kalau macam dah prolong sangat ulcer dia tu, so we need to investigate lah. Biasa kita akan refer them to the oral punya, to dentist lah, okay, untuk further check up sama ada mungkin it can be something benign saja ke, ataupun mungkin can be something that quite sinister macam oral cancer, okay. So oral thrush ni is usually berkait dengan those yang immunocompromised, okay. Macam patient yang HIV ke, immunocompromised patient yang on perhaps steroids, because they would come with this oral candidiasis lah, ataupun layman term dia kita panggil oral thrush. Bursitis, inflammation of your tongue, okay, it can be quite painful and uncomfortable, okay. Precancerous and benign neoplastic diseases, this is usually again associated with those yang immunocompromised and smokers especially, okay. Heavy smokers, they are prone to get this erythroplakia, okay, ni associated with heavy smoker ni. So you can see, kalau nak tengok normal oral mucosa, you see your epithelium ni, the mucosa are lined very nicely lah. Tak adalah nampak haywire compared to this one. So you can see there are some metaplastic ataupun dysplastic punya changes, and it is irregular, okay. And usually the nucleus are very big lah. Okay, kalau dekat mulut, the most common cancers are squamous cell carcinoma. Okay, again, smokers they are at risk to get this mouth cancers. Termasuk juga orang yang apa namanya makan makan sirih, makan sirih. Okay, betel nut punya ni leaf tu. So these are the risk factors. Okay, so what is the relationship between the location and the prognosis of cancer for oral cavity? So kalau the cancer tu is located on the lips, kat mulut, okay, biasanya dia ada macam prognosis tu is better lah, okay, compared to kalau the carcinoma or the cancer dekat floor of the mouth ataupun dekat the base of the tongue kat belah dalam tu. That one usually they have a poor prognosis. Alright, so that's about the mouth. Okay, mulut ni segala jenis penyakit boleh mula. And then we go to the esophagus. Okay, so bila when there are problems with your GI tract, okay, selalunya the patient would be presented to the clinic complaining of pedih ulu hati ataupun heartburn, okay, or dia mungkin they would complain of dysphagia. Dysphagia is difficulty to telan dalam English apa? Difficulty difficulty to swallow. Sekejap, dorang datang. Okay, difficulty in swallowing. Dia kalau lagi satu terminology tu achalasia. Achalasia dia susah nak swallow fluid, okay, compared to solid food. And then some people will also complain of discomfort in the abdomen, perut rasa tak selesa, perut rasa sebu, rasa berangin. Okay, and then if it's very 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 serious, okay, the patient may be presented with hematemesis or melena. Hematemesis ni muntah darah, you vomit out blood, okay, and melena ni adalah when you pass out black tarry stool, you punya najis tu hitam, okay. So kalau orang tu muntah darah, kita panggil tu GI bleed, gastrointestinal bleeding. Okay, so the problem is usually sama ada dekat esophagus ataupun dekat the upper part dekat stomach lah. Okay, kalau orang tu ada melena, okay, yang najis dia hitam macam rambut, okay, it's very very black tarry stool. Selalunya it is due to lower GI bleed. So pendarahan tu datangnya daripada from your usus lah ke bawah, okay. Kenapa kalau dia buang air besar tu najis dia berwarna hitam? Because the feces needs to travel. Okay, so dia ada bleeding dekat dia usus tu, and then when it travels, dia ambil masa, so the blood oxidize and bertukar menjadi hitam lah. Alright, so kalau ada dua ni, walaupun it's not common, but it is a dangerous sign. Say the patient might collapse because of the bleeding. Okay, so mungkin dia ada severe inflammation dekat dia punya esophagus ke, dekat dia ada bleeding ataupun perforated gastric ulcer ke, okay. So this can be a life threatening condition. Tapi selalunya lah dekat klinik, patient akan datang complaining of heartburn, perut rasa sebu, berangin, okay. So selalunya kita kena investigate lah why the patient comes with that complaint, right? Right, so biasanya in any diseases, okay, kita kena categorizekan the condition starting with congenital, and then inflammation ataupun inflammatory or infection, and then can be acquired ataupun primary and secondary, and last sekali adalah tumor. So tumor tu can either be a benign ataupun malignant tumor. So tumor tu tumor tu tak semestinya, it doesn't mean that you have cancer. Okay, tumor tu is just ketumbuhan. Okay, ada growth lah. So whether or not the growth is benign or cancerous, it needs to be biopsied and then sent for histo punya evaluation. Okay, so let's say kalau macam any one of you ke, your family members ke, bila doktor kata, okay we found a tumor in your stomach ke, tumor in your intestine ke, okay, jangan cepat panic because it can be just a benign tumor which can be treated lah, alright. Okay, back to this GIT. So it start off with congenital abnormality. Ni baby lah selalunya, can be a preterm baby ataupun baby yang ada some genetic problem ke. They may be presented with esophageal atresia. That means dia punya hujung ni blinded. Okay, ada blind pouch. Okay, so selalunya it will be associated with another condition yang kita panggil tracheoesophageal fistula. That means ada abnormal communication between lower esophagus and the trachea. So dia punya kesan dia apa? Nanti dekat dalam in utero, inside the womb, the fetus probably not able to swallow the amniotic fluid. So nanti mak dia ada masalah apa? Polyhydramnios. Polyhydramnios ni maksudnya air ketuban dia terlalu banyak sebab the baby is not able to swallow the amniotic fluid. Okay, so perut dia can be quite big lah. And baby tu masa lahir mula-mula tu mungkin nampak healthy initially, but then dia akan dapat respiratory distress lah sebab nanti bila dia minum susu tu boleh termasuk kat dia punya saluran pernafasan. Okay. Okay, so congenital banyak lagi lah tapi I just choose the common ones. And inflammation, GERD ni, gastroesophageal reflux disease. This is very very commonly seen. The most common esophageal abnormality. Selalunya disebabkan reflux daripada your gastric acid, okay, through the lower esophageal sphincter. And these are the risk factors untuk orang-orang for those to get this GERD. Okay, so nama lain GERD adalah reflux esophagitis. Alright. So dia boleh berlaku at any age. Even my son has this GERD and he's only 14 years old. So it's quite bad lah masa mula dia kena this GERD ni. Right? So symptoms selalu ada pedih hulu hati, rasa mulut tu rasa masam sebab the acid reflux. Reflux maksud dia tegurstan lah. Okay, there's a reflux of acid. Kenapa? Mungkin dekat LES tu dia tidak constrict very tightly, so it causes the acid to ghostan balik ke atas gitu. To how do you say, to revert back upward. Okay, so lama-lama kalau acid tu is chronically mengkakis, acid sepatutnya the mucosal membrane yang boleh that can withstand the acid is your gastric mucosa. Tapi dekat lower esophageal tu dia bukan, the mucosa is not the same as your stomach. So bila acid tu reflux, it goes up, dia akan inflame the lining of the LES tu. Dia akan kacau dengan dia punya the epithelial lining, and lama-lama chronic, kalau terlalu lama and it's not treated early, dia boleh menyebabkan changes of the lining. Menyebabkan metaplasia. So this can predispose to adenocarcinoma. Okay, kita panggil Barrett esophagus lah. Okay, so these are the management. Achalasia ni patient susah nak telan. Okay. Tak keluar apa-apa. Keluar lambat. Okay, so that's because there's a constriction ataupun stricture dekat the upper part of the stomach. Hiatus hernia is when you have part of the stomach dekat belah atas tu dia herniate, dia termasuk ke dalam opening of your diaphragm. So this is one of the cause untuk dapat GERD tadi tu. Okay. Kenapa dia naik ke atas? This is due to increase in the abdominal pressure as well as loss of diaphragmatic muscular tone. Okay, so you see sliding hiatus hernia is associated with reflux esophagitis ataupun GERD tadi. Okay, so you see patutnya is ada stricture lah. So this is achalasia. Normally dia akan lebar. So kalau hiatus hernia, part of the upper component of your gaster or your stomach slided upward. Okay, dia termasuk ke dalam this opening of your diaphragm. So dysphagia adalah difficulty in swallowing. Okay, so these are the causes. Esophageal stricture. Stricture maksudnya dekat sini, it means that there's a narrowing of the lumen. Okay, stricture maksudnya narrowing. Okay, so kalau dekat esophagus, there's a narrowing of the lumen of the esophagus. Kenapa there's a narrowing? Probably because of the chronic reflux esophagitis yang menyebabkan inflammation and then dia menyebabkan scarring, so dia menyebabkan the opening ketat lah, okay, sempit. Okay, ataupun kalau orang tu dia nak suicide, dia pergi minum paraquat ke whatever acid ke Clorox ke, so these are very corrosive substances that can mengkakis lah the mucosa of the esophagus and causing stricture. Alright. Okay, so neoplastic diseases cancerous lah selalunya. So yang ni I kata tadi, Barrett esophagus, kalau orang yang ada GERD, chronic GERD, and then it's not treated well, it's not managed early, the epithelium of the esophagus boleh bertukar daripada columna. Okay. Ni contohnya, ni kat lower part of the esophagus lah. So kalau kita tengok histo tu memang ada perubahan actually. So this is from the scope. Okay, so kat sini nampak very inflamed, merah. So this is a histology H&E of Barrett esophagus. Okay, yang mana yang abnormal ni kat sini. This one is normal mucosa. Ni cantik je dia punya ni columna. Okay, columna epithelium, and then dekat sini dia dah bertukar. Dia dah metaplasia. Okay. And then another type of tumor is the squamous cell carcinoma. Kalau Barrett tadi dia adenocarcinoma. Kenapa dia panggil adenocarcinoma? Because adeno maksudnya gland. Okay, yang ni squamous cell carcinoma lah. It's usually risk factor dia adalah orang yang smoker lah selalunya. Okay. Squamous cell carcinoma punya risk factors. What are the changes that can occur? Right. So you can see, okay. So ni memang kalau on naked eye, okay, after we have section the part of the esophagus, so we can see this is the SCC, squamous cell carcinoma of the esophagus. Okay. So this is the transition daripada Barrett esophagus to adenocarcinoma. So it doesn't happen very quickly. It takes time. Kalau biasanya pertukaran from one type of epithelium to another type of epithelium, sometimes 5 to 10 years lah, above 10 years selalunya. Alright. These are the comparison between squamous cell carcinoma and adenocarcinoma. So adenocarcinoma is usually associated with Barrett's. Okay. Okay, so far so good. You all okay lagi?
Okay.
Okay. Alright, so next one is stomach, your perut. Okay. Paling common juga acute gastritis. So this is a very common excuse that we usually get from students ataupun from staff that boleh datang MC, kenapa? Sebab gastrik. Okay. Kalau betul gastrik, you don't simply say you are gastrik lah, because if you are truly having a gastrik, you need to have yourself check up, kena buat scope. Okay, tak ada sakit perut je gastrik, sakit perut je gastrik. Sebab kita takut kalau betul-betul gastrik and you do not get it treated ataupun diagnosed early, sometimes the gastritis nanti dia akan kakis you punya the lining of the mucosa, the gastric mucosa. Kita takut dia punya complication perforated, dia perforated tu macam perforated tembus ni, something like that lah. So you can get bleeding, right? So it's a serious condition. Alright. So acute gastritis, this is an inflammation of the gastric mucosa. So you can see these are the precipitating factor. So kalau macam you all ada parents yang ada sakit lutut, nenek-nenek ke atuk ke yang sakit lutut, they have joint pains, and then the doctors prescribe them with apa tu kita panggil painkillers. You sometimes for girls pun kalau you have period pain, if you frequently ataupun religiously consume painkillers, okay, sakit sikit je ambil painkillers, sakit sikit je ambil painkillers. So macam a chronic injection of these painkillers ataupun NSAIDs ataupun certain drugs kan, dia boleh mengkakis you punya gastric mucosa. So you can get peptic ulcer atau this acute gastritis lah. Alright. So tak boleh lah suka-suka ambil ubat without being prescribed. Okay. Okay, so what are the signs and symptoms? You usually patient akan sakit perut, okay, rasa macam perut tu spasm, cramping. Sometimes they may also presented with nausea and vomiting, okay. So macam mana nak treat? There are medications lah, kita bagi antacid untuk kurangkan pengeluaran asid in your stomach, okay, ataupun histamine blocker lah. So this is through again gastroscopy ataupun OGTS, esophageal gastroduodenoscopy, skop daripada mulut sampai ke dia punya perut. So you can see the lining of the mucosa is very inflamed. Okay, yang ni pun dah inflamed dah sampai dah ada erosion dah dekat situ. Okay. And certain patient, they can move from ataupun they can progress from acute gastritis menjadi chronic gastritis. So selalunya penyebab chronic gastritis adalah ni, Helicobacter pylori. Okay, Helicobacter pylori ni bakteria lah. So selalunya macam mana kita nak check kalau orang tu datang macam a few times dia datang ke klinik complaining of stomach pain, dah bagi ubat all these antacids, magnesium semua tak jalan. So probably the doctor akan advise to do breath test. Okay, so nanti adalah satu plastic bag tu, dalam tu ada certain component. So the patient will need to exhale, dia tarik nafas dulu and then dia exhale. Okay, so the air yang the patient breathe out inside the bag nanti dia akan masuk dekat machine untuk di-analyze. So the machine akan measure dia punya urase. Jadi kalau urase is high because it's byproduct of the Helicobacter pylori. Kalau urase tu tinggi, that means there's a high probability that the patient is having Helicobacter pylori. So H. pylori ni memang the common culprit untuk menyebabkan gastritis. Lagi satu, macam mana nak confirm masa kita buat scope. Okay, masa kita teropong perut tu, the doctor akan ambil a sample of the tissue, buat biopsy, and then dia akan buat test lah dekat situ, boleh buat test terus. Dia ada dia punya kit tu, nanti dia letak sampel tu. Kalau kit tu the liquid tu bertukar warna, dah lupa dah warna orange ke warna purple, tak ingat dah. That means confirm memang ada Helicobacter pylori. Okay, so treatment dia kena ambil antibiotik for at least 6 weeks. Okay, sebab kita takut kalau kita tak treat gastritis ni, probably dia boleh menyebabkan something yang lagi serious lah in the future. Alright. Okay, so ni Helicobacter pylori. You see there's a lot of inflammatory cell dekat situ, white blood cell, sorry, dekat situ neutrophils. Okay, ni dia punya jadi microbe tadi tu, H. pylori. Okay. Okay, so this one I've mentioned just now, gastric ulcer. Okay, so this is when you have a break in the protective mucosal lining. Okay, so these are predisposing factors. So peptic ulcer is actually payung, is a big umbrella, peptic ulcer. Under this peptic ulcer, kita ada gastric ulcer and duodenal ulcer. Okay. So these are the predisposing factor. You see, peptic ulcer, for the first type, gastric ulcer, it's usually due to the over-secretion of your gastric acid. Okay, so what can cause this secretion? It's probably from the stimulation from your ACH, acetylcholine or gastrin or histamine. Okay, so in this gastric ulcer, if you if the person is a chronic alcoholic, selalu ambil certain corrosive medication, okay, ataupun recurrent gastritis, alright, you can get a breakage in the mucosal lining, alright, and then lama-lama dia akan membentuk ulceration dekat gastric wall tu. Okay. Kalau duodenal ulcer selalunya dekat bahagian bawah sikit lah, dekat your first part of the duodenum. Alright. The same thing just now. So ulcer, this peptic ulcer is quite dangerous because sometimes dia boleh perforate, dia boleh erode. Okay, dia mengkakir sampai ke belah dalam and then you can cause bleeding. Kadang-kadang patient boleh muntah darah. Okay, so this is a life-threatening condition. So you see, dia akan erode, makan ke dalam. Okay, so this is in your stomach lah, because you can see all the rugae here, lipatan-lipatan dekat dalam your stomach. So these are the signs and symptoms for peptic ulcer. Okay, and okay lah, signs and symptoms of peptic ulcer. These are the complications. You boleh baca nanti. And management wise, kalau patient tu bleeding, kita kena stop the bleeding and then kita kena stabilize dia punya vital signs. Kalau dia BP dia drop, so kita kena support lah bagi medication tu, maintain the BP, treat dia punya hypovolemic shock. Okay, so these are the medications. And carcinoma of the stomach ataupun cancer of the stomach, okay, selalunya can be seen in those quite elderly lah, 50 above. Okay. So again, H. pylori is the main culprit. Selalunya dia precede daripada chronic gastritis yang tak di-manage secara betul. Okay. So you see sampai boleh ada growth dekat situ. Alright. So this is the malignant tumor. Right, next is the intestine. Okay, ini normal. You can see all the crypts very nicely arranged in the columnar punya arrangement. Bowel obstruction selalunya can happen in babies ataupun at any age lah. Okay, so you can either have small bowel obstruction or large intestinal obstruction. Okay, and the obstruction can be due to hernias ataupun adhesion tu maksudnya dia melekat-lekat. Kalau patient tu pernah buat operation, okay, so bila ada scarring tu, the internal organ tu mungkin dia macam melekat-lekat, so it causes adhesion. Okay, or intersusception of bowel selalu dekat budak-budak. Okay, so hernia ni bila ada weakness or defect, hernia ni it can occur anywhere. Even dekat kita boleh ada umbilical hernia. Okay, hernia ni macam angin pasang. Anything that causes defect or weakness on the muscle ataupun on the wall of your cavity ke apa, and then ada increase intracranial pressure, dia akan tolak organ tu keluar through that weak spot tu. So yang terkeluar tu kita panggil hernia. Okay. Additionally, kata tadi kalau orang tu pernah ada history of surgical procedure, so dia menyebabkan ada pelekatan when they are healing. Okay, so contoh apa? Patient yang pernah ada history of cesarean section. Okay, first time cesarean section, second time pun cesarean section, third time cesarean section usually would take a bit longer untuk sampai ke dia punya uterus, because on the way nak sampai dekat dia punya uterine wall tu, there will be a lot of fibrosis and scarring punya addition. So nak kena tolak dia, nak kena potong-potong sikit. Okay, so it is one of the complication lah kalau kita buat any surgical procedure, especially if it involves your abdomen. Okay, intersusception ni adalah melibatkan the bowel. Selalunya kita tengok dekat baby, intersusception dia macam teropong. Dia termasuk macam tu. Okay, valvulus ni adalah twisting part of the GI tract. Okay, so ni herniation, any weakness dekat sini boleh menyebabkan the organ terkeluar. addition yang melekat-melekat. Interoception is like a telescopic punya abnormality, and valvulus bila dia anyone is talking? Would you like to ask me questions? Ada orang nak tanya soalan ke? Okay, so this is Crohn's disease, inflammatory bowel. Ada you all nak tanya soalan ke?
Tak ada kot.
Macam ada orang ni cakap. Okay, where was I? Crohn's disease.
Imat punya mic. Tak.
Imat punya mic. Where is Imat? Imaduddin. Imaduddin, can you switch off your mic unless you want to ask me questions? Alright, thank you. Okay, so apa tadi? Crohn's disease kan? Yang before this you all dapat tangkap ke apa yang I duk membebel ni?
Dapat.
Dapat. Next is IBD, inflammatory bowel disease. So inflammatory bowel disease kita ada dua lah kategori, Crohn's disease and ulcerative colitis. Okay, so Crohn's disease and ulcerative ni dua-dua ni adalah can be considered as a chronic inflammatory condition. Kenapa jadi we don't really know the exact cause ataupun the exact etiology. Tapi kalau dekat Crohn's disease, dia involve the lower part of the intestine, okay, the small intestine. And Crohn's disease dia melibatkan orang yang quite apa orang kata, quite young lah, around 20 to 30 macam tu. Okay, so it can be a very troublesome sebab 20 to 30 years old ni orang tengah buat apa? Tengah aktif. So dia punya sign and symptom tu sometimes boleh kacau dia punya lifestyle. Okay, and dekat Malaysia, usually kat Asian countries tak ramai sangat lah yang ada Crohn's disease. There are cases tapi it's not as common as dekat Western countries. Okay, IBD. Crohn's disease, one of the kerisauan, one of the things that we are worried about Crohn's disease adalah dia punya risiko to progress into carcinoma of the lower intestine, okay, ataupun small intestine. Okay, dua-dua tu boleh bertukar. They can progress to carcinoma, both Crohn's, tapi ulcerative colitis dia lagi common lah. Okay, so Crohn's disease dia ada chronic inflammation. Dia melibatkan the whole layer of the intestine. Okay, so kita panggil transmural. Trans maksudnya the whole keseluruhan. Okay, all three layers tu. Alright, and then when there's inflammation, nanti dia akan menyebabkan, because of the recurrent inflammation, inflame baik, so lama-lama dia akan menyebabkan thickening. Okay, because of the scarring. So bila dia thicken, dia akan boleh menyebabkan the opening of the intestine tu makin sempit. Okay, and then bila ada during the inflammation, dia juga boleh menyebabkan an appearance yang kita panggil cobblestone appearance. Okay, cobblestone appearance disebabkan ada edema, ada swelling dekat kawasan mucosa tu. Okay, ada, so swelling dia bukan the whole layer, tapi dia macam ada part. Okay, and then also lagi satu karakteristik dia adalah skip lesion. So dia ada macam affected area, normal, okay. So how do these patients manifest? They would complain of abdominal pain, and then dia ada recurrent diarrhea. Sometimes kejap-kejap boleh ada setengah orang tu sekejap orang kata constipation, kejap-kejap cirit-berit. Okay, dia macam selalu bertukar. But most of the time it's diarrhea lah, and because of that they may have some nutrient deficiency because there will be malabsorption. Occasionally patients can complain of fever, and then they can get obstructions. But remember, I told you, when there is recurrent inflammation, nanti dia akan heal through fibrosis to scarring. So this scarring can cause thickening, and the thickening can lead to narrowing. Okay, so it may cause intestinal obstruction. And then fistula, one of the complication. Fistula ni maksudnya abnormal communication between two structures. Okay, so contoh kat sini, you can have, sepatutnya normally you cannot have ada, kalau intestine sajalah, bladder sajalah, tapi because of the information tu tak tahu macam mana, okay, dia menyebabkan ada communication between the intestine and the bladder, kawasan yang dekat-dekat dengan your intestine tu lah. Okay, so ada macam communication, ada macam terowong tanah. Okay, so kalau macam tiba-tiba, contoh lagi satu ni, fistula between the intestine and the skin. So sometimes macam dia erode, and then dia keluar, dia punya information tu start from the intestine, and then dia erode sampai keluar kepada skin, and then we know one of the the end product of the intestine adalah apa, macam najis kan, ujung-ujung tu nanti macam membentuk najis tu. So sometimes you can see if there's communication, this abnormal communication, boleh ada macam liquid macam najis yang your apa, najis yang belum consolidate lagi sampai ke rectum tu, dia boleh keluar daripada skin. Okay, so that is an example of an abnormal fistula. Ni yang I kata tadi cobblestone, because of the swelling on the mucosal lining. Okay, you see ulcerative colitis, again this is a chronic inflammation of your bowel. Okay, beza Crohn's disease dengan ulcerative, Crohn's dia dekat bowel saja. Okay, problem dia dekat you punya usus. Ulcerative colitis dia ada extra intestinal manifestation. Extra intestinal maksudnya dia akan melibatkan other part of your body selain daripada your intestine. Dia boleh menyebabkan polyarthritis, dia boleh affect your joints, inflammation of your uvea dekat mata tu, ataupun dekat episclera, ataupun dia boleh affect your biliary tree, menyebabkan sclerosing cholangitis, inflammation dekat you punya biliary tract tu, sacroiliitis dekat your hip joint tu, ataupun boleh ada skin manifestation. So mungkin ada ada nodule. Okay, so you see ni is a bit serious sikit lah, because it involves other part of your body. Okay, so in UC, ulcerative colitis, the inflammation is limited to the large intestine. Okay, and dia akan selalunya dekat bawah sikit, dekat rectum. Okay, tapi kalau dekat di Crohn's tadi apa yang kata, dia boleh any part of the GI tract, tapi dia selalunya involve your distal ileum. Okay, kalau ulcerative colitis bawah lagi, okay, dari rectum satu. And dia ada creep abscess, that means ada ada kawasan yang macam kita kata ada nanah, abscess, and then bila kita buat H&E, there's a lot of neutrophils dekat situ. Okay. And sometimes you can have pseudo polyps. Nampak macam ada polyp, macam ada skin, macam extra isi kat situ, tapi it's actually not a true polyps lah. It's due because of the inflammation of the mucosa tu, menyebabkan dia keluar sikit, so nampaklah macam ada polyp. Okay, and patient kalau yang Crohn's disease, dia selalunya sakit perut, diarrhea, sometimes sembelit tukar-tukar. Tapi kalau ulcerative colitis ni, it is associated dengan bloody stool, ataupun dia punya najis tu bercampur dengan darah, sometimes bercampur dengan lendir, mucus. Okay, so that is the most frequent presentation untuk ulcerative colitis. And nak dikatakan, and it's also been said that between Crohn's and ulcerative colitis ni yang lagi serious lah dia punya presentation, because it can lead to a lot of complications, and one of the example of complications are toxic megacolon. Megacolon ni dia punya colon tu, mega is big. So the colon becomes dilated very big. So this is an emergency situation lah, sebab takut nanti dia boleh perforate. Okay. Perforate. And then high risk untuk carcinoma lah, colon, carcinoma of the colon. Okay. So ulcerative colitis in contrast to Crohn's disease, kalau Crohn's disease tadi dia ada macam skip lesion. Ada tak ada lesion. Tapi ulcerative dia akan involve selalunya the whole part, tapi usually at the lower GI tract lah. Okay, dekat-dekat dengan rectum sana. So this is quick abscess. So kat dalamnya ada banyak neutrophils. Okay, so this is the comparison between Crohn's disease and ulcerative colitis. So this is what I meant by skip lesion. Sini ada lesion, sini normal. Sini ada lesion, normal. Tapi kalau ulcerative dia akan bersambung, continuous, right? And it usually involves the lower part yang dekat-dekat dengan rectum tu. And then we also have another category selain daripada the inflammatory, kita ada congenital tadi, and then kita ada apa lagi, inflammatory condition. Now is the vascular disease. So vascular melibatkan your blood vessel. Okay, any vessels yang mungkin occluded with atherosclerotic plaque boleh menyebabkan obstruction. So nanti dekat kawasan tu dia tak terima blood flow, so nanti dia tak dapat oksigen, so nanti dia akan jadi ischemia. So bila ischemia nanti infarcted, boleh mati. Okay, bukanlah you mati, I mean the organ dies off lah, because it doesn't receive enough oxygen and blood supply. Okay, angiodysplasia is a term that describe there is an abnormal tortuous tu dia macam berliku-liku and then dilated, okay, vessels in the intestine or mucosa. Because it is abnormal, sometimes dia senang rupture, pecah. So it can lead to lower intestinal bleeding. Okay, and another common condition adalah hemorrhoids ataupun buase, ataupun in layman term in English kita panggil piles, is due to dilated internal and external venous plexus in the anal canal. So it usually due to macam orang yang tak suka ambil high fiber diet, tak suka makan buah, tak suka makan sayur, tak suka makan red meat, kurang minum air, and then if you have recurrent constipation, you increases the intra-abdominal pressure dekat situ. So lama-lama nanti you boleh ada pile. Okay. Alright, next is the tumors of the small intestine. Okay. It's common to get benign tumor lah selalunya dekat your GI tract ni. Okay. Most of the polyps, ketumbuhan tu, they are benign, but some can progress to cancerous punya condition or malignant condition. Okay. So benign tu I tak focus. I am focusing more on the malignant type lah. Okay, so the first one is adeno-CA of the small intestine. It usually involves your colon. Okay, and small bowel carcinoma usually they like to start at the duodenum. Okay, kenapa? Kita pun tak tahu. Okay. So this GI tract cancer or malignant condition, kita tak nampak because it's internal. So what do this patient usually presented? Sama ada dia just ada abdominal pain, crampy, sometimes nausea, macam vomiting. Ujung-ujung tu baru dia boleh ada systemic punya manifestation. Okay, weight loss, poor weight gain, apa lagi, loss of appetite. Okay, jadi makin lama makin kurus. Okay, tapi mula-mula tu there is no prominent symptoms. They may just be presented with, you know, the normal abdominal discomfort. Okay, tu yang kadang-kadang can be quite difficult to detect unless kalau patient tu smoker, dia ada all the risk factors, and then ada family history, and then mungkin dia presented with upper GIB or lower GIB, then baru kita akan betul-betul investigate lah. Okay, sometimes bila dia datang just a very general punya presentation, it's very hard to catch it early. Okay. Alright. Selain all these malignancy, ketumbuhan malignant tumor, a person also can get lymphoma. Okay, lymphoma ni selalunya melibatkan malignant changes of your lymph nodes. Okay, lymphoma. So adik-beradik dia macam leukemia lah, but leukemia usually involve your blood. Lymphoma is usually from the lymphoid tissue, your lymph nodes and whatnot. Okay, so kalau gastrointestinal lymphoma, it is usually more common in the Western countries, yang kita panggil mild lymphoma. Okay, mucosa associated lymphoid tissue. And this type of GI lymphoma selalunya dekat orang yang dewasa. Okay, tak kisah lelaki ke perempuan ke, and it usually involve the stomach. Okay, it's common site of the apa orang kata, the site for the lymphoma, MALT ni lah, MALT tadi. Alright, next is colorectal carcinoma. Okay, this one you pay attention jugalah. Okay, I want you to pay attention dekat apa, esophageal carcinoma, peptic ulcer, and gastric ulcer and duodenal ulcer. I want you also to focus on carcinoma of the colorectal, as well as the inflammatory bowel disease tadi. Okay. Okay, colorectal carcinoma. Colorectal carcinoma is a malignant condition that involves your colon as well as your rectum. Okay, one of the most common neoplasm in the Western world. We are also seeing a rise in this the prevalence of colorectal carcinoma in Malaysia as well. Usually it involves older people, 50 to 60 years old. Tapi ada juga macam ada a shift, mungkin sekarang ni macam a bit early, 50 years old pun dah boleh dapat colorectal carcinoma. I have few friends yang partner, dia punya spouse died due to colon cancer, and dia punya partner tu is just like 40 plus, 30 plus, dia dah dapat colorectal carcinoma. Okay, so one of the screening tool that we can use adalah kita boleh screen dengan tumor marker yang kita panggil CEA, carcinoembryonic antigen. Okay, so kalau patient tu ada high CEA, kita kena be wary lah. So probably kita kena investigate kenapa CEA dia high. So sepatutnya normal, you cannot have a high CEA. So this is a tumor marker. Alright, and usually it develops, dia tak, colorectal carcinoma, it doesn't appear suddenly. Okay, it usually started off with probably dia ada polyp, okay, ataupun dia ada chronic peptic ulcer ke. Okay, so this will slowly progresses to colorectal carcinoma depending on the risk factors. Okay, and it may take about 10 to 15 years lah for it to really show itself. Alright, so it can change or progress from a normal mucosa, and then probably starting with adenomatous polyp, and it changes to carcinoma, and then dia akan metastasize. Metastasize means it has spread to the surrounding area and it goes to the other part of the body. So stage 4 lah selalunya tu. Alright, so the characteristic untuk colorectal carcinoma, selalunya it can be divided whether it is an adenocarcinoma. Remember, adeno means it arises from the glands, okay, or there is a carcinoma of the rectosigmoid colon, okay, or you can get carcinoma of the right colon. Okay, so ni dia punya progression from normal, and then you can get an adenoma, and then dia lama-lama dia ada dysplastic, and then metaplasia menjadi carcinoma. So carcinoma, this is invasive sebab dia dah pergi, it has already infiltrate the inner part of the wall and then dia punya sepatutnya ni, dia punya lining ni, dia punya columnar dia satu. Tapi ni dia dah macam overlapping. Okay, and the nucleus are big. Okay. So this is an example of a gross observation on the adenocarcinoma of the colon. Ni satu, sini satu. Okay. And ni probably it started off with polyp and then it grows big into a cancerous tumor. And ni scope daripada bawah, okay, from the anus and then it goes up to the duodenum. So what causes? The exact cause is unknown, tapi there are evidences that say certain risk factors gives you a higher chance of getting this colorectal carcinoma, especially if you are elderly, you are a smoker, and then you have a very strong family history of cancer, ataupun you punya lifestyle. Okay, tak suka makan sayur, buah, okay, low fiber, and then suka makan red meat. So your diet also predisposed to this colorectal cancer, right? Okay, ni age more than 90% of the colon CA is found in people age 50 years and above, strong family history of colorectal cancer ataupun adenomatous polyp. Okay, so I have a friend who has this familial adenomatous polyp. That means it is hereditary. Okay, she has it. Her sister passed away because of colorectal cancer. She has this familial adenomatous polyp. So sekarang ni she has to go for colonoscopy yang scope daripada bawah tu every 6 months to see if the polyp is increasing. Okay, dia akan buat the surgeon akan reset, akan buang polyp tu, and every 6 months dia kena pergi follow up lah. So to make sure that the polyp doesn't change doesn't progress to apa orang kata cancerous punya stage. Okay. And if you have a family history of colorectal cancer ataupun sometimes in any other cancers pun dia boleh predispose you for colorectal cancer. And of course inflammatory bowel disease, Crohn's and ulcerative colitis especially. Ini yang modifiable risk factors. Okay, modifiable because if you stop smoking, if you reduce fat in your diet, if you have healthy lifestyle, okay, optimum body weight, okay, you can reduce the risk of getting colorectal cancer. Signs symptoms macam saya kata tadi, in any of the in any of your organs in your system, sometimes cancer ni masalah dia, it doesn't really present directly. Okay, sometimes you don't have any sign or symptoms at all, so it can be susah lah kan, because you do not get it or you don't catch it very early. Okay? And if there are signs and symptoms, it may include bleeding from the rectum ataupun masa you buang air besar ada keluar darah. Anything that's bloody, you need to get it investigated. Okay? Ataupun there's a change in your bowel habit. Sebelum ni tiap-tiap pagi buang air besar, normal stool. Normal stool tu depends juga. Ada setengah orang najis dia lembut, dia kata tu normal. Ada setengah orang najis dia keras macam tai kambing tu. Okay, macam najis kambing bulat-bulat, dia kata tu normal. So it depends on your own end product. Okay, tapi if you rasa tiba-tiba selama ni you punya najis tu very soft, okay, and then suddenly ada darah, tu you need to get it checked. Mungkin just hemorrhoid saja, ataupun mungkin ada luka, okay, ataupun mungkin kita tahu ada polyp ke, so you need to get yourself checked. And then suddenly bertukar daripada soft tiap-tiap hari buang air besar pagi soft saja, tiba-tiba dia bertukar diarrhea, and setiap sembelit, and then setiap ada together with mucus, so you perasan dah bertukar, kenapa ni? Is it because you have change in your diet ke apa, so you need to find out and then need to get it investigated. Okay, and one of the complications from this bleeding, kadang-kadang bleeding tu kita tak nampak, occult bleeding, you can get iron deficiency anemia because you lose blood and then you don't know, so you can get anemia lah, right? And who should be screened for colorectal cancer? Okay, people over the age of 50 or those with risk factors. So macam mana nak buat screening? Kita buat Colonoscopy. Colonoscopy tu scope daripada from your anus, and then the fiber optic scope tu dia akan travel sampai to the second part of the duodenum. Okay. So kalau nampak anything suspicious ke, the surgeon boleh ambil biopsy lah daripada situ. Okay. So ni the test tadi I mention, colonoscopy. Sigmoidoscopy ni sampai dekat sigmoid colon sajalah. Okay. Fecal occult blood test ni kita ambil sample of the feces, and then kita tengok under microscope to see if there's any blood. Okay. Double contrast barium enema, this is macam x-ray tapi kita inject dye. So nak tengok kalau macam ada stricture ke ataupun ada growth ke. Okay. So nampak ada macam x-ray, kita tengok bowel tu. So different types of polyp. Okay, so this is a polyp. This is another polyp. Ni actually ni bukan this is actually the mouth of the faucet biopsy faucet. Ni dia tengah nak clip the polyp tu. Okay. This is another polyp. Okay. Selain daripada the faucet tu, the surgeon can also guna loop wire ni. So the loop akan pergi masuk dekat go onto the polyp, and then the twist, dia akan tarik. Okay. Polyp remover. This is another polyp. Pedunculated maksudnya dekat sini dia ada macam tangkai, there's a neck. Okay. So polyp ni can either be dia macam dia terletak seketul sebiji onto the surface of the mucosa, ataupun it can be a pedunculated. Pedunculated tu that means there's a stalk, ada neck dia macam ada tangkai, so dia terkeluar sikit. Alright. So these are the things that you can do to reduce the risk of colorectal cancer. And lastly, acute appendicitis also very common. Selalunya dekat orang-orang school going children, 20, 30 years old, okay, dapat acute appendicitis. So acute appendicitis, how do they present? It can start with general abdominal pain, and then lama-lama the pain will be focused on your right iliac fossa. Right iliac fossa tu dekat belah kanan bawah, okay, bawah sekali, because that is where your appendix lie, right? So bila doktor tu tekan, very painful lah, very tender. Patient boleh ada fever, boleh muntah, nausea, vomiting, sometimes they can get diarrhea, okay? And it needs to be selalu bila kita suspect patient tu ada acute appendicitis, kita kena buat urine test juga, sebab kita takut kita nak exclude urinary tract infection, sebab sometimes UTI, urinary tract infection, can present with abdominal pain, with nausea, with vomiting. Okay, sebab kita tak ada nak kata patient ni datang je dengan lower abdominal pain on the right, this is acute appendicitis, pergi masuk OT. No, so kita kena exclude dulu. Mungkin dia just presented with urinary tract infection. So kalau betul dia punya urine tu ada bacteria, white cell pun tinggi, so kita just bagi antibiotic and usually the condition akan resolve. Tapi kalau dia punya urine test tu comes back clean, and then kita ambil darah, tengok white blood cell dia very high, patient is in pain, high grade fever, then kita akan proceed with orang kata with operation lah, okay, removing the appendix. Alright. Okay, so this is just sharing with you types of endoscopy, which is a common diagnostic tool to treat ataupun to diagnose any GI diseases. This is endoscopy. Ni dekat dalam endoscopic room lah. Okay, so this is the scope. So kita ada dua jenis. Sama ada is upper endoscopy or lower endoscopy. So kalau upper, dia start daripada mulut sampai esophagus, perut, sampai ke first part of the duodenum. Kalau lower endoscopy, kita panggil colonoscopy lah. Okay, start from your anus, goes up to your rectum, and then ileum, then colon, your transverse colon, and second part of the duodenum. Okay, so upper GI endoscopy, so patient will be lying on the side kita akan bagi dia sedative supaya dia tak rasa sakit lah. Okay, and then ada macam mouth guard dekat situ, and then dia akan masuk. So kita akan suruh patient tu telan. Okay, and then it travels, and so we can see the monitor here showing you the appearance of the structures. Okay, sebab dekat hujung scope tu ada kamera. So this is colonoscopy. Sigmoidoscopy ni dia selalunya dekat sampai sigmoid sajalah. Okay, from the anus rectum up to your sigmoid. Okay, so during endoscopy we can do biopsy, we can resect the polyp kalau ada. Alright. Okay, so tu saja. Macam mana? How are you guys hanging so far? See, penuh dengan ilmu dah, you punya otak ni dah kembang dah.
Okay.
Any questions for GI pathologies?
Doctor, according to the polyps punya removal, kalau contohnya dia remove the polyps, will it happen to reoccur again ke?
Yeah, that is a possibility for the polyp to recur. Boleh. Any other questions? Tak ada, semua okay. Alright. Yes, saya.
Saya curious kalau macam buang polip tu kan, jadi doktor kata macam dia tarik kan, macam yang terkeluar tu macam siap terus tarik, lepas tu tak payah jahit doktor.
Tak, dia takkan jahit. Dia ada, bila dia guna loop tu untuk kepit dan tarik, dia akan ada bleeding sikit lah. Okay, if the bleeding is very trivial, sikit saja bleeding, kita can just let it be like that. Tapi kalau macam kita tengok bleeding tu a bit agak banyak, the surgeon boleh burn kat kawasan situ untuk stop the bleeding.
Oh, thank you doktor.
Okay. Okay, so it's already 1 o'clock. If you have any questions, again you can forward the questions to Rahman and I will answer them accordingly. Remember to log into your iTat link for today's attendance. Okay, alright. So semua okay? Bertahan lagi?
Okay.
Alright. Okay, so thank you very much. We close the session with the recitation of by reciting the Surah Al-Asr and Tasbih Kafar.